Thank you everyone for joining tonight's OTEP clinical case webinar. Tonight's topic is the effects of opioid use on the GI system. I believe the title is a little different. It's now Opioid-Induced Gut Dysfunction, Constipation, and Beyond. So thank you, Dr. Kortt, for creating this presentation and the fun title. We have Dr. Kortt tonight, who is a clinical lecturer at the University of Sydney, as well as a staff specialist at Drug Health Services and the Liver Clinic in South Sydney Local Health District, and also a gastroenterologist and hepatologist. So very fit to give this presentation. I'd like to begin. Oh, thanks, Nick. I'd like to begin by acknowledging the traditional custodians of the country and lands on which we meet and recognize their continuing connection to land, water, and culture. So these are just some of the registrations for tonight. So we have over half of the people are coming from metropolitan local health districts, but we do have about 15 people from other states other than New South Wales joining, and pretty good representation from around the state, as well as many GPs and pharmacists, but also a lot of addiction medicine.
It's a pleasure to be able to present tonight on something which affects many of our patients on opioid agonist therapy. There are opioid receptors throughout the entire body, a substantial number in the enteric nervous system, which results in an umbrella terminology which have labeled opioid-induced gut dysfunction, which often we consider constipation, but there's opioid receptors throughout the gastrointestinal system. So it has profound effects throughout the gastrointestinal tract. And by the end of this presentation, I'd like everyone to be considering other components of opioids on their effect on other components of the gastrointestinal tract. So a brief outline of what we'll discuss this evening. We're looking at the epidemiology of opioid agonist therapy in Australia and looking at the burden of opioid-induced gut dysfunction. We're trying to determine some of the burden of opioid-induced gut dysfunction. We'll discuss the molecular and neurophysiological basis of opioid actions on the gastrointestinal tract. We'll look at some of the clinical presentations of opioid-induced gut dysfunction, so looking at constipation, given how common this is, it's affecting the stomach in terms of gastroparesis, esophageal dysmotility, and sphincter of body dysfunction. And I'll highlight clinical assessment of patients with these conditions, workup and management. In terms of management of constipation, look at laxatives that can be used, as well as some of the less commonly used pharmacotherapy, such as Pamoras, which I'll go into in greater detail what the acronym stands for later in this presentation. So why does this matter? Well, I have a patient here. He's a 42-year-old male. He's been on methadone for a while, 9 years. He has Hep C, has treatment, has a history of depression, and he's a smoker. And he tells you one day that he's passing only 2 bowel motions per week and he's got straining. He feels full early, he's early satiety, has postprandial nausea, some intermittent epigastric pain, as well as reflux. And every now and then he gets this crampy colicky right up for pain after he eats dinner. He has a constellation of potentially gastrointestinal symptoms, which could all be related to opioid use or from other underlying pathology. So we have to think about how common are these symptoms in opioid agonist therapy. What of these symptoms could be driven by opioids or other pathology? I'll be discussing and just talking about why we don't get the same degree of tolerance in the gut compared to tolerance to opioids you get in the central nervous system. Why might this person be having right upper quadrant pain? What does that have to do with opioids? And what are some of the medications that we can utilize for symptoms related to opioid-induced gut dysfunction, which are safe and effective? So opioid-induced gut dysfunction I use as an umbrella term to describe all the components in the gut that are affected by opioids. It's a whole tract disorder. It affects everywhere from the mouth all the way down to the rectum and anus. So in the stomach, think about opioids which contribute and can cause gastroparesis. They can contribute to reflux, delayed transit in the small bowel. In the colon, they can cause opioid-induced constipation, fecal impaction. They affect the biliary tree as well as the pancreas, increase sphincter body pressure and can result in sphincter body disorder. And they affect esophageal motility, resulting in motility disorders, which can resolve with withdrawal or rejection of opioids. So it affects the entire gastrointestinal tract, and is very common, which I'll highlight in subsequent slides. So looking at how big the problem is, so in terms of patients on or clients on OAT in Australia, in 2024, according to the Australian Institute of Health and Welfare, there's about 56,000 individuals on opioid agonist therapy in 2024. Now, the majority of these, 55%, were on buprenorphine, majority were male, and they're about 40 to 59 years. It's sort of an age bracket where people are starting to develop more medical comorbidities and be on more medications, which can act synergistically with opioids to affect the gut in more profound ways. There is an increasing growth in the number of clients on opioid pharmacotherapy, but that is somewhat commensurate with the increased population. Now, note, buprenorphine has taken over methadone prescribing in Australia, and that's come about with the advent of long-acting injectable buprenorphine. So we're seeing that more people are on bup versus methadone, and this does have some correlation with the sort of side effects in the gastrointestinal tract that one may experience. But of note, buprenorphine and methadone both cause a substantial number of opioid-induced gut dysfunction. It's just, in some cases, buprenorphine may cause lesser effect. Looking at how common this problem is, how common? It's very common. In terms of gut dysfunction in opioid agonist therapy, most information comes about studies looking at constipation in particular. There are studies that look at symptoms such as nausea, but it's hard to come by opioid agonist therapy studies looking at definitive esophageal dysmotility or definitive diagnosis of gastroparesis. But in this one study over here on the left with the bar graph, we have a cohort of patients in Italy, over 1,000, just over 1,000. And you see that only about 8% reported no constipation, and more than 50% were reporting moderate to severe constipation based on the Wexner Constipation Severity Score. Now, in a cohort in Australia, there's a publication from Paul Haber and RPA where they looked at patients on buprenorphine and methadone, as well as patients that were using heroin or other opioids that were illicit. They identified 60% of patients on buprenorphine reported constipation, 65% on methadone, and it was a similar number of individuals using heroin only. We can compare and contrast that to the population of chronic opioid-treated patients for pain. And there's this one study called the PROBE survey, which looked at a large volume of individuals. And they found that 46% of patients reported constipation despite laxatives in chronic opioid use, but not on opioid agonist therapy. Now, I make mention of patients on opioid agonist therapy or opioid substitution therapy compared to patients on chronic opioids for pain. They're different populations, but often the medications that are being recommended in some guidelines for treatment of opioid-induced constipation are all based on studies that have been conducted in populations of patients being treated with opioids for chronic pain. Now, in chronic pain, typically the dose of analgesia is whatever the lowest dose is to treat the symptoms. In opioid substitution therapy, we're often using much higher doses. If you look at high doses of buprenorphine and methadone converted to oral morphine equivalents, you're looking at numbers like 1,000 oral morphine equivalents. And those are the sort of doses that most people with chronic pain are nowhere near. Treatment of our clients and for opioid substitution is typically long-term, years, decades, and it's often less so for chronic pain, but not always. Polypharmacy is common in patients on opioid substitution, as it is for patients with chronic pain, but there's often more psychotropics being used as well as illicit drug use. And there's always there tends to be an increased degree of stigma related to patients' opioid substitution therapy. So perhaps there's less reporting of their symptoms to their clinicians. So let's look at the pathophysiology of why opioids affect the entire gastrointestinal tract, and this is important. There's the central nervous system with abundance of opioid receptors, but the enteric nervous system also has an abundance of opioid receptors, mu, kappa, delta. They're throughout the entire gastrointestinal tract, the mesenteric and submucosal neurons. Now, the mu opioid receptors drive the predominant side effects and the predominant cause of things like constipation. Now, in terms of the effect on the neurons, activation of the opioid receptor, particularly the mu opioid receptor, results in adenyl cyclase, a decrease in adenyl cyclase, which inhibits calcium channels from opening and opens potassium channels, which ultimately results in a decrease in the release of acetylcholine from excitatory motor neurons, which results in a loss of coordinated peristalsis. So you have less movement in the entire gastrointestinal tract, which is particularly important in the colon, which can result in things like constipation. Now, opioid receptors are also important in secretion of chloride and water into the lumen. An activated mu opioid receptor, to a lesser degree delta, results in less chloride secretion, less water flux into the lumen. So you have drier, harder stool, which results in a bit of a double hit in terms of creating complications such as constipation. You have less propulsive movement and less fluid being excreted into the gut lumen, so therefore drier, harder stool. So interestingly, you don't have the same degree of tolerance to opioids in the gut as you do in the central nervous system. Now, this slide does oversimplify the pathways that are involved and the differing degree of tolerance depending on the gastrointestinal organ. But in the CNS, there is something called a beta-arrestin 2-dependent receptor internalization. So mu opioid receptors that are activated by an opioid are internalized utilizing beta-2 arrestin. And that internalization results in progressive desensitization because you have less of these receptors being expressed on the cell surface. But in the enteric nervous system, there's not the same degree of the beta-2 arrestin mediated desensitization that particularly applies to colon. So that means constipation tends to persist long term. You don't develop this tolerance to side effects, to that effect, as you do in the CNS to the effects of sedation or respiratory depression. So the implication of this is that things like opioid and constipation on an opioid agonist typically lifelong unless you're able to reduce the dose of the opioid agonist, which may relieve the constipation. So patients need an ongoing bowel plan, not just a short course of treatment. And you can't simply say that those symptoms are going to wear off with time. Of interest, the peripheral-acting mu opioid receptor antagonists bypass this tolerance issue without reversing analgesia, and I'll discuss the action of these pomoras in subsequent slides. So let's first talk about opioid-induced constipation, because why? It's the common thing that we'll see. So it's often undertreated and perhaps not reviewed on such a regular basis as should be required. So our first patient, our first case that we'll discuss is this patient who is a 35-year-old man. He's been on methadone, 80 milligrams, started about 6 months ago. He's had a recent increase in his dose because he was using intermittent heroin from 60 up to 80 milligrams. He's reporting to you on your latest review that he's had about 4 days of constipation. Has opened his bowels for approximately 3 days, and he finds that he's straining open his bowels. He's got bloating and mild nausea. Doesn't have any red flag symptoms. He's not bleeding. There's no fever. There's no weight loss. He has an examination, no mass, no abdominal distension. His abdomen is soft and non-tender. Now the question is, what's our best step? What should we do next? Glad we have that sort of advice. So we'll talk about why one might be choosing one over another. The correct answer that I put in was be, and we'll discuss why that might be a better option for this patient in this situation, why increasing fibre or water intake might not be that effective in opioid-induced constipation. So first up, the diagnosis of opioid-induced constipation. Well, there's a Rome criteria to diagnose opioid-induced constipation. It's a discrete entity beyond just idiopathic constipation. And the criteria is new or worsening constipation when initiating, changing or increasing in opioid therapy. And it includes two or more of the following, which are experienced 25% or more percent of defecations. Those symptoms are straining, lumpy hard stools, sensation of incomplete evacuation, sensation of anorectal obstruction, utilizing manual maneuvers to facilitate stool passage, and fewer than 3 spontaneous bowel motions per week. Now, we make the diagnosis of opioid-induced constipation. It's important to not forget about potential masqueraders or other causes of constipation. We should be thinking about whether somebody has mechanical obstruction from, say, a mass restriction. Often don't have red flag signs, or an examination, distended abdomen, obstipation. Thinking about electrolyte disturbance or metabolic causes of constipation, such as hypercalcemia, hyperkalemia, hypothyroidism. Consider pelvic floor dyssynergesia, which is also called defecatory dysfunction, which worsens with opioids, but somebody would have symptoms suggestive of this condition prior to opioid initiation. Don't forget things like inflammatory bowel disease. So things like Crohn's disease can present with constipation due to a restricting phenotype of Crohn's disease. And there are some tools that can be utilized to help with assessment of somebody's constipation. The classic Bristol stool chart. So a patient can identify what sort of stool type they have if they're having trouble with describing it to you. If it's unclear how often they're opening their bowels or what type, they can complete a stool diary. You can also perform something called a bowel function index. I can't say I use it in my day-to-day practice, but you get a score out of 100, and more than 28 is indicative of constipation. It's just asking 3 simple questions about somebody's bowel function, and useful to compare the degree of improvement over time in a numeric value. So what are the complications of opioid-induced constipation in our population? Well, there's reduced quality of life. So in a study by again in Italy, where they looked at the quality of life for patients with constipation on opioid substitution therapy, they found quality of life scores were similar to those patients who had severe IBS constipation type. And a large proportion, over 40%, had some degree of psychological distress. There are complications of chronic constipation. So you can develop hemorrhoids, painful anal fissures, fecal impaction, very rarely sterical perforation, but it can happen, urinary retention, and overflow incontinence. It can potentially affect our clients' treatment adherence. So they may miss doses, want to reduce doses, or return to illicit substance use if they had less GI side effects compared to being an OAT. They may self-medicate by using things like stimulant laxatives, particularly high doses or without supervision. So we should move on to management of opioid-induced constipation, which is a stepwise approach. So this is just an outline of a stepwise approach, which I'll go through in a bit more detail in a second. But we have the foundation, the sort of preventative measures, which are hydration, fibre, and mobility. Then onto the pharmacological measures, things like osmotic laxatives, stimulants. Next, we go to things like considering alternative causes for the constipation, looking at offending co-medications, and considering reducing doses or transfer, and then using third and fourth line pharmacotherapy, like the peripheral acting opioid receptor agonists, which are rare to use and are difficult to access. And that's why I've left them to the last part of this stepwise management. So in terms of step 1, the prevention and lifestyle interventions, hydration and fibre are important, but they're often not efficacious on their own in patients with opioid-induced constipation. So you should be targeting for adequate hydration, and that varies from person to person. There's no one right amount of fluid for one person versus another, but typically I say around 2 liters of fluid, but it depends on somebody's activity and size. And obviously less in patients who are older or have any comorbidities such as cardiac or renal comorbidities. Fiber intake. Fiber intake recommended for adult males is about 30 grams. For females, it's about 25 grams of fiber a day. Its effectiveness in opioid-induced constipation is limited because you have less secretion of fluid into the gut lumen. So if you give somebody a large volume of fiber, particularly something like psyllium, it can actually absorb extra fluid and cause more bulk, but without improving necessarily stool consistency sufficiently to result in more effective bowel motions. So it can actually worsen impaction in some people, particularly if they're not having enough fluid in combination. Movement is important. Somebody who's very sedentary is more likely to have constipation, but it just is regular, gentle exercise is effective in promoting bowel motions, but it's not as if people have to go to the gym or go running a marathon. Consider constipating co-medications and see if those can be reduced or stopped potentially. So things like anticholinergics and oral iron replacement are classic causes of constipation. Patients should be instructed about a good bowel routine. Most people, almost everyone has something called a gastrocolic reflex, which they experience after they eat. Typically happens after breakfast or other meals during the day, where sometimes a few minutes to half an hour to an hour afterwards of consuming a meal, there's a reflexive colonic movement, which is essentially the bowel trying to move things out to make way for what's coming in. And that's the time when people are most able to have an effective bowel motion. If people try to open their bowels outside of the period where they're experiencing the gastric colic reflex, can result in increased straining and failure to effectively open one's bowels. You can consider prophylaxis in patients who are already experiencing constipation prior to starting on opioids, because their opioids are never going to make this better. It's always going to make it far worse. So you're trying to start something to prevent their constipation getting far worse. So considering macrogol or docusate, which is coloxyl. In terms of first line of pharmacotherapy, there's nothing groundbreaking here, but Movicol or macrogol or Osmolax considered first line therapy. So typically 1 sachet a day. The reason this can be effective in opioid-induced constipation is because you have often dry, hard stool because you have less fluid being excreted into the lumen. An alternative, which is less volume, is lactulose. But lactulose is typically a less effective agent. It can also cause a bit more bloating in many of our clients or many of my patients. You can add in as an adjunct coloxyl, which is docusate sodium. This is not a particularly effective agent as a monotherapy at all, but it acts as a bit of an surfactant and softens the stool to allow more penetration of fluid and softening up the stool a bit further. So useful when somebody is reporting hard stool and can be used in combination with the osmotic laxatives. Now, it's useful to be telling your patients how quickly they expect to respond to this. It's not an overnight fix. It takes a bit of time for the effect of these osmotic laxatives and stool softeners to take effect. At least a few days, 2 to 3, but you should really ideally be reassessing the response in a week, which I know is difficult in our clinical setting. In some patients, I'll give them a plan that they can take control of some of these medications themselves, and if they're not getting adequate bowel motions after 1 week, they can escalate to, let's say, 2 sachets of Movicol after that duration of time. So they're not having to come back to see a doctor on a regular basis just to escalate. Something that's really quite safe to be escalated in a patient-directed manner up to a certain point. Now, in terms of second-line treatment, if step 2 is not working, first of all, you want to assess what the stool is like, what the frequency of bowel motions is like. Are they still passing hard pellety stools? Well, ideally, you want to be getting a bit more fluid and softening the stool up. Are they passing soft stool, but they're just not getting frequent enough bowel motions? then you might want to be giving something to help stimulate that peristalsis. So in this case of somebody having hard, solid stool, increasing the macrogol mobicol is a reasonable thing to start off with. You can double the dose. And macrogol, you can have quite a substantial amount as per the product guidelines, up to 8 sachets a day in case of trying to rescue somebody from severe constipation. Not that I'm recommending somebody takes that amount on a regular basis. If their stool is relatively soft, you can add in a stimulant laxative such as senna or Dulcolax, which is bisacodyl. You have varying degree of response to these stimulant laxatives. I have some patients who have quite a substantial bowel motion if they only have 5 milligrams of Dulcolax. So I usually actually recommend starting with a lower dose, taking it once a night, and waiting for effect before increasing that dose. If you have non-response to the stimulant laxatives, you can use PR treatments, so things like microlax, glycerol suppositories, and like I said before, large volume macrogol or movicol, so you can use up to 8 sachets of movicol. In hospital settings, sometimes in my outpatients who I look after with chronic constipation, or utilize bowel preparations such as Moviprep in select patients to help clear out stool if they're really suffering from constipation, and then try to re-establish their bowel regimen with lower dose laxatives from there on. Now, we're expecting a response from our stimulant laxatives a little bit more rapidly than osmotic laxatives. They typically take effect within 24 up to about 72 hours. Now, once you've started these laxative regimens, you should be, again, looking to assess effect after a period of time, up to about 4 weeks before escalating to another pharmacotherapy or reassessing and seeing if you've missed something. Now, I'm skipping along in terms of pharmacotherapy that's available while we're on this topic to the next available pharmacological means of treating opioid-induced constipation, which are the peripheral mu-opioid antagonists, or the PAMORAs. These block intestinal mu-opioid receptors without crossing over the blood-brain barrier. So they restore that gut function and peristalsis while not precipitating withdrawal, but not readily available in Australia, unfortunately. So there's a few agents that exist: naloxegol, naldomidine, and methanoltrexone, but one that is available in Australia is the methanoltrexone, but only a subcutaneous preparation. And it's typically used and indicated in Australia for opioid-induced constipation, palliative care, or chronic non-cancer pain. It does cause potentially quite a large volume bowel motion. It can cause abdominal pain and significant cramping when utilised. But given its subcut use and the fact that it's difficult to have somebody on this long term, it's not a particularly practical option. But rare that one would have to consider this as an option in our cohort. Now, refractory opioid-induced constipation. Is there something beyond methanoltrexone in our standard line of laxatives? Yes, there are new agents that exist which have varying degrees of evidence and availability in Australia. These agents are being repurposed from treatment of chronic idiopathic constipation. So there's a group of medications which are called intestinal secretagogues. They stimulate chloride and therefore water secretion into the lumen of the gut. Lubiprostone, linaclotide, and plecanatide. Lubiprostone has FDA indication for opioid-induced constipation in chronic non-cancer pain. And the other 2 agents don't really have that degree of evidence or support, but they're not available in Australia to use, unfortunately. In terms of what is available in Australia, we do have something called prucalopride, or Resitrans, which is a tablet that can be taken. It's a 5-HT4 receptor agonist. So serotonin is an important neurotransmitter in promoting peristalsis in the gut. Activation of these receptors results in increased acetylcholine release and also peristalsis. But there really isn't great evidence to support this for use in opioid-induced constipation. So it really has to be utilised when all else fails, and it's very much off-label and relatively expensive. But before we get to these third and fourth line agents, you should be really revisiting, have I got the right diagnosis? Is there something else we can do? Looking at history that might make you think they've got defecatory dyssynergesia, or considering reducing your opioid agonist therapy, or perhaps switching to an alternative agent, be that which would be buprenorphine, given its pharmacological properties. So switching someone from methadone to buprenorphine might help with constipation. I say it might help because there are series which indicate that there's less constipation in individuals on buprenorphine compared to methadone. We're looking at this one meta-analysis over here on the left-hand side of the screen. They reported buprenorphine versus methadone. There's a relative risk of 0.76 in favor of buprenorphine regarding constipation, but the confidence interval crossed over 1, so it was between 0.57 and 1.01. Indicating there's a trend towards buprenorphine causing less constipation than methadone, but not statistically significant based on this meta-analysis. So it may help, but it's not guaranteed to do so. So if you're thinking about switching over from methadone to buprenorphine for management of gut symptoms or side effects, consider discussing with an addiction medicine specialist if you're not. The induction or transition needs to be planned and discussed with the patient so they know what they're in for in terms of the transition, and also setting realistic expectations. Your gastrointestinal symptoms may improve, but they may not vanish completely, or they may continue. Although there's a trend towards the fact that you will have less side effects on buprenorphine. You should still be using your bowel regimen if you make this transition and reassess a month or two after the transition has been made. So moving on from constipation, we go to other parts of the body. So we've gone from the colon up to, in this case, the upper gastrointestinal tract. So this is case 2. We have a 48-year-old woman who's on Suboxone, 16 milligrams. She's been on it for 2 years, and she's stable on that dose. She's not on any other medications. She's been experiencing early satiety, nausea after meals, and bloating, and occasional non-bilious vomiting. Her bowels open every 1 to 2 days, which is only slightly less than before she was on Suboxone. She has no dysphagia, no weight loss. What do you think is the most likely opioid-related gastrointestinal problem in this case?
Nick, I'm not sure if the screen is... Oh, never mind. It just caught up, and I'll share the Zoom poll.
Okay, thanks, Jess.
So 86% chose A and 14% chose B.
Excellent. Okay, good job, 86% choosing A. So this is in an opioid, patient on opioid agonist, suggestive more so of gastroparesis with SIBO, more likely to get something like diarrhea and bloating more commonly. But in somebody who's on an opioid, you should be thinking about the opioid inducing the gastrointestinal symptoms as your primary diagnosis. So gastroparesis in patients on opioid agonists. So opioids can be a cause of gastroparesis and also a contributor. They can make underlying idiopathic gastroparesis worse. So what's the mechanism of opioid-related gastroparesis? There's a few effects that opioids have on emptying the stomach. Opioids increase tonic contraction at the pylorus, so you have increased outlet resistance. So food cannot pass from the stomach into the small bowel as effectively. Opioids also cause decreased coordinated contraction of the antrum, which results in the food not being broken up into small pieces effectively, which is one of the main roles of the antrum, to break the food up into small particles. There can be less accommodation of the fundus, which allows more food to enter the stomach, resulting in early satiety and nausea. And interestingly, methyl nitroxide can reverse those morphine-induced gastric emptying, which It's highly suggestive of a peripheral mechanism of opioids affecting gastric delay. In terms of symptoms you may experience in gastroparesis, nausea, vomiting, early satiety, postprandial fullness, and bloating and epigastric pain are all common. Symptoms usually are persistent. They're worse with solid meals, less severe or absent with liquids. Liquids can pass through the pylorus based on the pressure gradient, whereas solid meals have to be broken up by the stomach into smaller pieces in order to pass through. Diagnosis usually involves endoscopy to rule out a structural obstruction and gastric emptying, study off prokinetics to confirm that there is delayed gastric emptying. So management of opioid-related gastroparesis, well, ideally, if somebody's on chronic opioids and they have a diagnosis of gastroparesis, if you can optimize the opioids first, that's going to reduce either the effects of idiopathic gastroparesis or reverse opioid-induced gastroparesis. So it can be, the dose could be reduced or dose could be divided so you have lower peak effects of a particular medication, which is, again, I understand, often not particularly practical. You consider an alternative agent or formulation. Long-acting injectable buprenorphine has less peaks and troughs, so potentially that lowers that peak effect that can worsen gastroparesis. Dietary modification can be very effective in gastroparesis, so eating smaller frequent meals and avoiding foods which are high in fat and fiber because they're more easily broken down in the stomach. Liquid calorie diet can be very well tolerated, though many patients practically don't enjoy it, because again, those liquid calories easily transition from the stomach through the pylorus based on pressure and don't have to be broken up by the stomach. Prokinetic agents can be improve symptoms, so metoclopramide, domperidone, both potential options. And erythromycin can be highly effective in treating gastroparesis, but it develops a tachyphylaxis, so the effect can wear off with some time. It's important to consider nutritional support for these patients with dietitian input. It's fairly uncommon to have to use NG or peak J feeding in these individual patients, but certainly that would be discussed in a specialist setting. So from the stomach, we're going in a slightly opposite direction. We looked at the esophagus and esophageal dysmotility, which has been something that's sometimes overlooked or under-recognized. So next case 3, we've got another poll. There's a 58-year-old man who's on methadone. He's on 120 milligrams daily for 11 years. His dose has escalated recently. His dose escalated about 18 months ago to increase cravings. And he's noticed a relatively long, about 6-month period of progressive dysphagia to solids and liquids, intermittent retrosternal pain after meals, no weight loss, no hematemesis, no anemia. Now, he has had a gastroscopy. This is a man over 50 who's got new dysphagia, which is always of a concern. And the gastroscopy was unremarkable. No mucosal lesions, no strictures. He went to have high-resolution manometry, and it showed clinical type 3 achalasia. So impaired lower esophageal relaxation and some premature spastic contractions in the esophagus. What's the next most appropriate step for management of this man?
And so we have 25% who chose A, 30%
Yep.
who chose B, and 42% chose C.
Oh, interesting. Bit of a split there between A and B, and then reducing the methadone dose. Well, let's have a think about how we might manage this. But if we think it's opioids that have induced the esophageal dysmotility, the answer would be C, to try to reduce the methadone dose. Appreciating that we can't always just reduce the methadone dose because we're worried about relapse or using other substances. But in many cases, the dysmotility of the esophagus has purely been driven by the opioid and can be reversed by reducing or stopping opioids. So what do opioids do to the esophagus? These are 3 distinct types of opioid-related effects of on the esophagus. Can cause type 3 achalasia, which in some case studies looking at patients diagnosed with type 3 achalasia, which is where you have impaired lower esophageal sphincter relaxation and premature spastic contractions. About 50% of patients in this group we're on chronic opioids. It can cause a esophagogastric junction outlet obstruction. We have increased pressure at the bottom of the esophagus, but normal peristalsis. And can also cause distal esophageal spasm. We have increased number of premature contractions in the esophagus, which can cause pain and dysphagia. Now, with opioids and the effect on the esophagus, typically the results are dose dependent. So higher dose equivalents, higher morphine equivalents typically predicts increased disordered peristalsis and relaxation at the bottom of the esophagus. So you can reverse these effects by reducing the opioids. What sort of assessment would be relevant to somebody with an esophageal dysfunction or somebody who's suspected that? Be a timeline. Do your symptoms correlate with opioid initiation and dose change? Or do they predate the opioid initiating, indicating there's another underlying source? What's the symptom character? Are the symptoms more so with liquids versus solids or both? Symptoms with liquids suggests a little bit more that it's dysmotility versus an obstructive cause. Assessment would usually be with a gastroscopy manometry. So you think about management priorities. This opioid reduction, where feasible, is often going to result in resolution or improvement of symptoms. Rotation can also be considered. Treatments can include modified diet. So again, more liquids, calcium channel blockers, nitrates, pyrokinetics, all have some potential benefit. And invasive treatments, which are POEM, which is peroral endoscopic myomectomy or myotomy, are reserved for really severe cases where opioid reading has failed. And just outline some red flags symptoms over here on the right-hand side of the screen, such as unintentional weight loss, onset of dysphagia in people over the age of 50. Now, I'll just skip through this slide because it rehashes what I just mentioned before in the interest of time. Maybe we'll just look at this case quickly. Yes. So we have a 52-year-old man who's had 15 years of opioid-induced disorder. He's on methadone, 90 milligrams, and he's increased it recently in response to heroin use. And he's developing some intermittent right upper quadrant pain, which is typically postprandial. He's never been jaundiced. And on imaging, he has a slightly dilated common bile duct, no stones, no gallbladder thickening, no obvious obstruction there. And he has some mildly elevated bilirubin. His LFTs are only mildly abnormal there. So what could this possibly be secondary to? Oh, good job. I think the topic of our presentation is probably indicating why it would be B. So we're looking at sphincter of Oddi dysfunction. Why does sphincter of Oddi dysfunction occur in chronic opioid use? Well, because opioids raise biliary pressure. They increase the basal sphincter tone and phasic contractions, which results in increased pressure at the sphincter of Oddi. And sphincter of Oddi is where bile and pancreatic fluids are excreted out through into the duodenum. So it results in increased intrabiliary and intrapancreatic duct pressure and delayed bile and pancreatic fluid drainage, which can result in a dilated common bile duct, which can be intermittent or chronic. So clinical presentation can include recurrent right upper quadrant pain or epigastric pain. You can have transient LFT derangement, particularly those cholestatic LFTs, but with cholestasis, you can absolutely get a substantial transaminitis with a raised ART and AST. You can see a dilated common bile duct without any obvious obstruction. That's important. If you have a sign of obstruction like a stone, it's not sphincter of Oddi dysfunction. There, you can potentially have somebody developing idiopathic recurrent acute pancreatitis, and the symptoms are sometimes reproducible after a dose, as in that tend to be precipitated by doses of opioids, but not in all cases. Now, it's important to rule out more common classical causes of obstruction, such as choledocholithiasis, ampullary tumors, chronic pancreatitis, which could be causing this abdominal pain or biliary type pain with appropriate imaging. which I'll outline subsequently. Now, of note is that patients on chronic opioids have an increased incidence of asymptomatic biliary dilatation. And so this is sometimes under-recognized and doesn't always require substantive investigation beyond appropriate imaging. So there's a few studies which have demonstrated that cohorts of patients on who have opioid-induced disorder or opioid agonist therapy have increased common bile duct sizes. So in the middle, we have a cohort, relatively small, but identified common bile duct dilatation in 50 out of 222 hepatitis C infected substance users, but they found that the odds ratio of current methadone being associated with CBD dilatation was 20. And another study where Bates et al. Looked at patients on chronic methadone and reported that the average diameter of the common bile duct was 1.4 millimeters greater than in matched controls, and the PD of the pancreatic duct 0.9 millimeters. So in patients who have on opioid agonist therapy, they've got normal LFTs, no pain, and isolated common bile duct dilatation. Don't necessarily need more investigations than appropriate imaging. In terms of management of sphincter body dysfunction, first of all, need to rule out physical obstruction first. So that's with imaging, ultrasound, plus minus MRCP, include things like stones and strictures. Bloods with your LFTs as well as lipase/amylase. During episodes and between episodes, usually with sphincter of body, you expect the liver function tests to improve as the pain subsides because it's transient obstruction that's typically occurring. And in specialist centres, we're considering an EOS diagnostic uncertainty persists. And treatment of sphincter body dysfunction is with an ERCP, but this is in selected patients. ERCP with sphincterotomy and sphincter of body dysfunction, I should say, carries a quite high risk of pancreatitis, with rates up to about 30% being reported, which is really high. So patients with this condition are really highly selected by interventional gastroenterologists before proceeding with the RCP to make sure that benefits will outweigh the risk. No, I'm just going to move forward because I realize getting close to 7 o'clock. So I might just go through these conditions. I might just skip narcotic bowel syndrome. Sorry, guys. I know it's exciting, but I do want to mention teeth because teeth is something we do think about a bit in opioid agonist therapy, but not always. But the gastrointestinal tract starts in the mouth, and sometimes easy to forget. And opioid agonist therapy has multiple effects on our oral health. That's for a few reasons. It can cause xerostomies, dry mouth, reduces saliva production. There is definite evidence that there are increased sugar cravings in patients on opioid agonist therapies, particularly methadone. So they tend to eat more sweet foods. The number of times I've seen people drinking a Slurpee or a 7-Eleven coffee with a bunch of sugars in them in an OT clinic. There's increased risks of bruxism in OT patients. And there's definite access barriers to dental care due to social and economic reasons. Now, of note, there was an FDA safety alert in 2022, specifically related to Suboxone, so buprenorphine naloxone films, where there was an increased rate of reported dental adverse effects. Which is thought to be due to the Suboxone film being acidic with prolonged exposure to the teeth causing demineralized enamel. So that's included as a safety alert now in the US. So there's a reason that people on Suboxone might have worse dentition than on other opioid agonists. So we'll just outline some red flags of when to refer in somebody who has constipation. So some of these will be obvious, but I'll just outline. If somebody has obstipation, their inability to pass flatus or stool, if they've got abdominal distension, they should be heading towards the emergency department. If they have severe abdominal pain, particularly if it's persistent and localized, recurrent vomiting, especially if it's bilious, because that's a little bit more indicative of obstruction. If they have evidence of GI bleeding, substantial weight loss, stool, which is a substantial change in caliber, so pencil thin stool, or if you perform a rectal examination of palpable mass, or significant rectal pain, any neurological signs, or they have a substantial family history of colorectal cancer or inflammatory bowel disease. I should also mention referring patients if you suspect they have the non-opioid induced constipation complications. This is all very reasonable. Referring for suspected achalasia, esophageal dysmotility, gastroenterologist is all very appropriate and recommended. So in terms of the practical algorithm of assessing these patients, I think should always be looking to review GI symptoms when we review a patient on opioid agonist therapy in clinic. Asking questions about stool form, frequency, things like straining, the reflux, early satiety, and abdominal pain. Assessing them using tools like the Bristol stool chart, targeted exam, blood tests, and abdominal X-ray. If you think they've got stool impaction, you want to assess the location if they've rectal impaction. Ultrasounds for abdominal symptoms, and look to things like exclude red flag symptoms, which are a reason to refer on. Treatments, escalating from lifestyle osmotic plus minus stimulant laxatives. Reserve things like opioid dose reduction or transfer if first steps are not effective. And refer to a gastroenterologist for the reasons I outlined before. So in summary, GI dysfunction in opioid agonist therapy is very common, but you need to ask patients about the specific symptoms. They don't often let you know on their own account. Think about the whole tract all the way from the mouth down to the colon. Tolerance doesn't always develop in the gut, particularly in the colon, so things like constipation are lifelong. Use stepwise approach in terms of management. And I added in that patients who have opioid-induced bowel dysfunction, it's causing some sort of pain, like sphincter or body pain, or if it's causing constipation, it causes abdominal pain, or if it's causing epigastric pain from reflux. If you increase the opioid dose, those symptoms tend to get worse and the pain gets worse. So it's not a good way to responding to that, to gut-derived sources of pain.